evening, everyone. Thank you for joining us for our TIF Talk tonight. We are so excited to have our special guest with us. I'd like to introduce to you my colleague, Haley Catalano, out of Nashville this evening. My name is Wendy Profit. We are both with Endogastric Solutions and are so proud to welcome Dr. Navid Monajjem. Thank you for being with us tonight.
My pleasure. Thank you for having me.
Just to tell you a little bit about Dr. Monajjem, he practices at Vanderbilt Integrated Surgical Services in Shelbyville, Tennessee. He received his Doctor of Medicine from Ohio State University, the Ohio State University, as I'm told, and completed his residency in general surgery at the University of Mississippi Medical Center. Dr. Monajjem has authored several medical publications, is board certified by the American Board of Surgery, and his special interests include minimally invasive surgical techniques, including the TIF procedure for reflux. Welcome, Dr. Monajjem.
Thank you very much, Wendy. Again, glad to be here.
Thank you. So, everyone, as you may know, this is a live webcast. We would love to invite you to ask your questions regarding GERD, any issues that you might be having for Dr. Monajjem. We will get to those throughout the broadcast. Dr. Monajjem, let's go ahead, jump in and talk a little bit about GERD. What exactly is it? What do your patients typically experience?
I'm glad to talk about that, Wendy. GERD, you know, it's a pretty catch-all phrase now. It's an acronym, stands for gastroesophageal reflux disease, and the key word there is reflux. That's what everybody usually comes into the office and says. They say, "I've got reflux, doctor. I can't stand it." But from our standpoint, there's a pretty wide, long list of potential symptoms that can arise from reflux. But the real basic principle is that things that are supposed to stay in the stomach are not staying there and coming back up into the esophagus, which is the tube, the muscular tube that sends food from the mouth down to the stomach. And so, since the stomach is an acid-containing organ, when that acid gets up into the esophagus, that usually causes the most common symptom, which is heartburn, a burning sensation right back behind your chest bone. But there can be a lot more complex symptoms that can occur with reflux, and long-term symptoms can cause some more significant life-threatening problems. And we usually recommend that things get done to fix reflux early on in the stages rather than later.
Very good. Thank you very much. Can you talk a little bit about the symptoms that patients most commonly complain about when they come in for an appointment with you regarding GERD?
Well, sure. Heartburn's number one. Almost 90 to 100% of patients complain of heartburn. Next most common are things such as pressure in the chest, bloating when they eat, sometimes difficulty in swallowing things. Food doesn't seem to go down into the stomach like it's supposed to. We spend about 30% of our lives lying down in bed. And so a lot of symptoms are nighttime symptoms. They wake up in the middle of the night with burning in the throat or choking or coughing. And it can even mislead us into thinking there might be something wrong with the lungs or the airway when it might actually be reflux of stomach contents up into the vocal cords or the lungs that cause those symptoms.
Interesting. Yeah, we talk with a lot of our guests who say that this complaint, you know, that they talk about with folks who are coughing quite a lot. Oftentimes they see more of them in the springtime for whatever reason. Sometimes they think it's allergies. They finally go in and see a doctor, an ENT maybe, thinking it's related to allergies, when in fact they end up getting referred to someone like yourself to tackle the real problem.
That's right.
So can you talk a little bit about how your GERD patients say they've attempted to manage their symptoms, you know, and what are your recommendations for managing GERD?
Well, there's not anyone that's walking on this planet now that hasn't experienced GERD in one way or another. An episode of heartburn is common. Everybody has it every once in a while. When you start getting it a little bit more often, such that it bothers you or takes your attention, it's such a common problem that nowadays, your neighbor, your brother, your sister, your dad, your mom, they've had it. We're inundated with commercials regarding medicines for reflux. And so the first instinctive step is to go out and get a medicine that's for reflux, quote unquote, for reflux. And this is an unwise approach, mainly because reflux is not just acid coming up into the esophagus, but it's an anatomic derangement, and those medicines do nothing for the loss, say, of the valve mechanism between the stomach and the esophagus. And what happens is you relieve symptoms, but you're not really taking care of the underlying problem, and the long-term risk from these issues become hidden, and you don't see the doctor. It's really important with reflux. Once you start getting symptoms such that you feel like you need to do something about it, get to your doctor first, or let them arrange for a referral to a specialist that can evaluate this, because it's treatment of not just of the acid, but the anatomic problem that's really going to be durable in the long term and have a more beneficial effect of removing those long-term risks.
Excellent. Thank you. Are there, we've talked a little bit with folks in the past who have mentioned just some short-term potential fixes, including, elevating the head of the bed. Are there foods that you recommend folks either ingest or avoid to help? Is there any merit to those cures out there that folks talk about, as far as apple cider vinegar, anything along those lines that you hear people talk about?
Yeah, that's a big one. Just like with just about any other disease, there's a continuum of severity. Very mild reflux disease usually can be treated with an appropriate lifestyle change, avoiding eating several hours before going to bed or lying down, avoid reflux-prone foods. Most commonly, these are tomato-containing products. It's different for everybody. Spicy foods, just about any food that your regular doctor would say try and stay away from or use moderation because of your risk of cholesterol or heart attacks or heart disease or stroke. Those are the foods that you would also want to limit when it comes to reflux. Even foods that you would more commonly associate with constipation can increase the retention of food in the stomach over a long period of time, and which also promotes reflux. So these are individual matters mainly. It's different for everybody, but paying attention to your diet, being conscious of what you eat and its effect, is going to be the best way for you to achieve overall dietary health, as well as minimize reflux.
I don't think anybody's really touched on foods that stay in the stomach longer than others, at least in my recent memory. Can you talk a little bit about those, which ones they can expect to have that effect?
Well, high fat, any food that has a large amount of fat in it slows down gastric emptying. The gastric emptying mechanism holds on to that for a little bit longer, holds on to the food a little bit longer. But just in general, the functional disorders of the colon, for example, chronic constipation, irritable bowel syndrome, those also can have manifestations further up the stream in the stomach, and so they can be interrelated.
All right, very good. Gosh, see, there's something I didn't know. I thought the fatty foods just blocked your arteries, but there you go, a double whammy. All right, so can you talk a little bit about what unmanaged GERD can lead to?
Right. So as long as that anatomic derangement allows food or acid to come up into the esophagus, you're at risk of changes taking place in the esophagus that are dangerous. Our body, as miraculous a machine as it is, has the ability to change the lining of our intestines to react in reaction to some kind of insult. And so the esophagus lining is not designed to be exposed to acid. And so what happens is it changes itself into the cell type that's normally in the stomach or in the intestines, which so that it can become resistant to all that acid that's coming up from the stomach. That's called metaplasia, and that is dangerous. That's the dangerous first step that can lead to cancer. And I think it's important for patients to realize that esophageal cancer is increasing in frequency, and there's growing evidence that it is directly related to the degree of untreated or poorly treated reflux.
Wow. Okay. Thank you very much. Yeah, we'll be touching more on that over the next several weeks as we approach Esophageal Cancer Awareness Month. So I really appreciate you touching on that for us. Can you talk a little bit about the tests when a patient comes in and complains of symptoms? Through consultation with them, you discover they could be a suspect for having GERD. What do you typically do then to further them, along the treatment pathway?
So we concentrate on the two issues that are present with reflux disease. One is the patient's anatomy. That means how has their valve between the esophagus and stomach been deranged in any way? Is it open? Do they have something that's called a hiatal hernia, which is an opening in the breathing muscle that normally is tight around the esophagus and stomach, loosens and allows the stomach to slide up into the chest? Do they have an abnormality of the anatomy of the esophagus in some other way, an anatomy, a blockage in the outlet of the stomach? These are all anatomic problems that we need to make sure are present or not present to explain the reflux. And then the other issues are functional issues. Is there truly reflux of acid coming up into the esophagus? And we can measure that with pH testing. Is there a problem with the esophagus transmitting the food from the mouth down to the stomach? Are the muscles not working well? There are specialized tests to evaluate that. Once all that information is compiled, then a recommendation can be made as to how we can treat the problem.
Very good. Thank you. All right. I am going to take a break for a second, turn it over to Haley, who has advised we have some questions. And Haley, go ahead, take it away.
Awesome. Thank you. Yep, we have some really good ones. So a couple. Christina is asking, do you have to lose weight? I'm assuming she means to be a candidate for the procedure.
Well, I mean, that depends on what weight we're starting at. Okay. And it also depends a lot on other factors that aren't just purely based on the patient's weight. Now, there's a evaluation of weight or healthy weight that's called the body mass index, or the BMI. We usually like the BMI, which is a ratio of weight and height, to be less than 35 before we would consider aggressive surgical treatment of reflux. But that's variable. We can treat reflux pretty much at any BMI, but we prefer it to be lower than that. In addition, it also depends on the degree of therapy that's needed. If a patient has significant anatomic derangement that requires a more aggressive surgical treatments, then those can and should be done regardless of the patient's weight. If we are somewhere in the middle of the spectrum where we have mild to moderate reflux symptoms that require medication use 24 hours a day, 7 days a week, then we can consider the less invasive, procedures that have lower side effect profiles and that do have some weight restrictions. So no, you don't have to lose weight necessarily to be a candidate for any of these procedures, including the TIF procedure or hiatal hernia repair. But we always recommend weight loss in folks that are overweight, not just for their candidacy for this procedure, but for overall health.
Sure. Absolutely. Okay. All right. So Lisa is commenting and questioning. She says, I take PPIs daily. I'm tired of taking them, and I don't think that they're helping much anymore. How can I get off of them?
Yeah, that's an excellent question. And that's probably the most important reason why patients come and see us. And that is they're tired of taking medicines. They want to get off the medicines. Well, like I said before, the medicines are there to block acid. Medicines won't work if the reflux itself is uncontrolled. So you can block acid for a period of time and it may work a little bit for the symptoms, but it's not going to work for your underlying problem. And so the only way to really get relief and get off the medicines is a thorough evaluation of your anatomy and then the correction of that anatomy. That by far is the gold standard of treating reflux. That is correcting the anatomy, fixing a hiatal hernia if there was one present, so that acid or anything is not coming up into the esophagus. If you're not having anything in the stomach come up into the esophagus, you're not having heartburn and you're not having any of the other symptoms of reflux.
Absolutely. Okay. And we'll do one more for now, if that's okay, Wendy.
Yes.
Lynn says, hi, Dr. Monajjem. Does GERD ever simply go away on its own?
Well, it can, I guess, and it sort of depends on how you talk about GERD. There's a balance here. So if we've got somebody that has a BMI of 35 or is significantly overweight, and because of that, they're having significant reflux, it's possible that they get down to, they lose weight, take a good, healthy diet, lifestyle change, and reflux goes away. And that includes not just heartburn, but just reflux. They might not have a very large hiatal hernia. It's just that the weight, which causes the increased pressure in the belly, was just enough to create symptoms. They lose the weight, the symptoms go away, and therefore the reflux goes away. So again, in that situation, it's going to be important to evaluate the anatomy. If there's a large hiatal hernia, it's unlikely that symptoms are going to go away with just weight loss, and there's going to be additional recommendations. But otherwise, yes, it is possible for weight loss by itself to resolve reflux symptoms.
Okay. Excellent. Wendy, back to you. We've got a few more that we'll get to in just a little bit.
Perfect. Thanks, Haley. So, Dr. Monajjem, can you talk a little bit about the TIF procedure and how it works?
Right. So, a little bit of a history lesson's important here. The gold standard procedure that we've talked about, which is called a fundoplication or the Nissen fundoplication, is named after a surgeon from a long time ago by the name of Rudolf Nissen. And this was back way before we knew anything about laparoscopes or that laparoscopic surgery was so common. And that procedure is still considered the gold standard, but I don't know, about 20, 30 years ago, we perfected the laparoscopic approach for that. And that procedure became widely utilized for everyone that had reflux disease as the cure-all for that problem. Unfortunately, we realized fairly quickly that with the high numbers of that procedure that were being performed, that there were some trade-offs. Your reflux went away, but problems such as gas bloat and swallowing difficulties started replacing reflux symptoms and bringing patients right back to the doctor with the exact opposite series of symptoms. And so we we tapered off the use of that procedure really and reserved the surgical wrapping of the stomach around the esophagus by whatever degree. For the really serious major anatomic defects in the little small section of the continuum of reflux from asymptomatic up to severe reflux. And that unfortunately left a whole bunch of other people, everybody else with reflux, relying on medications. And those medications revolutionized reflux with the institution of PPIs. Peptic ulcer disease, ulcers, and reflux essentially disappeared. And everybody was on them, had very safe side effect profiles. Now, however, going into about 20 to 30 years into PPIs being in existence, we're realizing that there's some associated side effects from being on those medications for too long. And so where TIF and the laparoscopic hiatal hernia repair, as well as the TIF, comes in is to fulfill the desire of patients that want symptom relief and want to get off the medicines, but don't necessarily meet the criteria to perform the more invasive, higher side effect surgeries at the other end, at the bad end of the reflux spectrum. And so it's opened up a whole world of opportunities because the TIF procedure has a far more favorable side effect profile. There aren't trade-offs essentially associated with that procedure. That procedure is done completely endoscopically, doesn't require surgery. It reestablishes a more anatomically normal valve between the esophagus and the stomach, and has very few, again, problems with gas, bloat, or swallowing issues. And so it's a great addition to the armamentarium of the reflux surgeon to provide relief for a whole segment of patients with reflux that otherwise wouldn't have any other options.
Excellent, thank you. So can you talk a little bit about, we've heard TIF and we've heard hiatal hernia repair. Can you talk a little bit about how those two can work together?
Yes. So there were two mechanisms associated with reflux, and we decided that one was loss of the valve mechanism that allows the stomach to retain food and acid and keep it from going up into the esophagus. And the other is a widening of the hiatus between the esophagus in the chest and the stomach in the abdomen. And that those two together create the environment that promotes reflux. Of course, there are some people that have hiatal hernias that don't have much reflux, and there are some people that have a loss of the valve mechanism between the stomach and the esophagus without much of a hiatal hernia. But the vast majority of people have some degree of dysfunction of both. And so when we talk of the TIF procedure, I view the TIF procedure as the a solution for recreating the valve between the esophagus and the stomach, and a hiatal hernia repair as repairing that widening of the hiatus to keep the stomach down into the chest. And in many patients, if not most, that dual approach is the best way to have a durable, long-standing effect on reducing or eliminating reflux.
Excellent. And so I guess the hiatal hernia repair just in essence also keeps that valve, that repaired valve, right down where it's supposed to
Sure.
be, correct? Okay.
Right. Yeah. I mean,
otherwise it can push up into the chest.
Yeah. If you were to see the procedure itself, it would make sense that why leave the opening really wide so that my valve goes up into the chest. It doesn't make any sense, and it's common sense to think that if there's a weak area in the body, it needs to be closed, and if there's a dysfunctional valve, the valve will become dysfunctional very quickly if the opening isn't closed around it. So.
Okay, very good. Thank you. Can you talk a little bit about what most commonly draws your patients to TIF as you discuss options with them?
Well, of course, when patients come to see me, they want relief. They want to be able to say, I don't want to have to wake up in the middle of the night coughing or having to reach for my Tums just to keep the burning out of my chest. I don't want to have to keep taking a pill in the morning and at night in order to stop the heartburn. And so it's not very long while taking medicines that may or may not work before they start seeking other answers. And so those are usually the patients that I see. They come in with some sense of frustration that this medicine they've been taking for years and years is not working, or it never worked at all, or they're tired of continuing to go to the pharmacy to get a new prescription for the different type of acid blocker because one of them didn't work, and they eventually run out of options. So.
Very good. Okay.
Yeah, we actually have a question in regards to what we were just talking about. If we could go back to repairing the hiatal hernia if the patient has one. Dr. Monajjem, Corey is asking, can just repairing my hiatal hernia fix my reflux alone?
Yes, it can. As a matter of fact, I've done it a couple of times, such that yes, and it provided relief. The problem occurs is that not all hernia repairs are durable, lifelong. There are circumstances which don't allow, or which allow a hernia that's present to become weakened again and opened up. And without repairing the valve mechanism, it's more likely that such a scenario will cause recurring symptoms faster. So, yes, we could release the stomach from the chest, repair the hiatal hernia, and that keeps the stomach down into the chest. But the entire complex mechanism that prevents reflux involves both repair of the hiatus or an intact hiatus and reestablishing that gastroesophageal valve mechanism. And this is the reason why we can do the TIF procedure alone on folks, because they're having reflux despite having no evidence of a hiatal hernia on all the testing. And they benefit by reestablishing that valve mechanism, but they won't necessarily require a hiatal hernia repair. So by the existence of that kind of scenario, it makes sense that if you're going to have a hiatal hernia repair, that you're going to need some kind of reinforcement of the valve. And anatomically too, it would be extremely rare to have a hiatal hernia alone without some kind of effect on that valve mechanism, because that the junction between the esophagus and the stomach becomes completely deranged as long as the hiatal hernia is in existence.
Okay, thank you. Yeah, just wanted to clarify that. Excellent. We've got a few more questions, Wendy, but we can wait for those or get to them, whatever you think.
Oh, you know what? Go ahead, fire away. Let's do it.
Okay, so John, I'm assuming a Nashville native, is asking, if I get the TIF procedure, can I still eat my Nashville hot chicken?
Sure, you just have to take it to your surgeon first and let them try it and have some with you, and then you can go ahead and eat it. No, Nashville hot chicken absolutely is on the menu. It is, and I'm never a believer in cold turkey in anything. It's certainly not advisable for you to eat Nashville hot chicken every day for supper. You're going to be in trouble for many other reasons other than just reflux. But yes, the purpose of surgical repair of reflux disease is to eliminate the chance that anything in the stomach is coming up into the esophagus, no matter what you eat, and you can reward yourself with a Nashville hot chicken every once in a while if you want to.
Okay, in moderation, it sounds like.
Moderation in all things.
Okay, so Lynn is asking, is chronic throat clearing possibly a sign of reflux?
It is. Most definitely, Lynn. Throat clearing course, it can have a bunch of different causes, and it's important to have those other causes evaluated, especially when it comes to smoking and cancer risk. But if all of those tests don't reveal any other kind of problems, then it certainly is worth it to check for reflux, because sometimes reflux at night can be silent. If you're on PPIs, you don't have any kind of heartburn, your acid's blocked. But when you lie flat, stomach contents continue to come up into the esophagus and can sneak up there and get down into your vocal cords without waking you up. And so clearing the throat, chronic cough, worsening of asthma, all of these can be manifestations of reflux disease if all of the other causes that are much more common are ruled out, so to speak. Then it's certainly worth it to investigate the reflux as a possible source.
Okay. Okay, going back just a little bit, and you touched on this, but I want to make sure we get to Amber's question. She says, I've been on PPIs for over 5 years. Should I be concerned about long-term side effects?
Well, I guess that depends on how old Amber is. If Amber is 30 years old, then yes, because if you've been on it for 5 years, it's unlikely that you're going to end up off of it. Unless you make some other changes depending on your situation. And so, yes, you should be concerned. Amber, if you're 80 years old and you've been on it for 5 years, then there might not be as much of a concern. And so it's probably still important to at least ask your doctor, is this something I should consider to come off of? And if you're willing to undergo a few tests and have a potential surgical procedure, then we can go down that road to see about getting you off those medicines, even though your risk of long-term side effects is low.
Okay, all right. Last one for now. Derek says, what is the success rate you've seen personally from TIF?
My success rate so far is well over 90%. And by success, that would be about a 2-year to 3-year follow-up and no recurring symptoms.
Okay.
And now, of course, I don't have the long-term experience of other surgeons who have published their work. And there's lots of good published evidence that up to 85 to 90% of people are either on reduced or off their acid blockers and symptom-free over 5 years, and now even up to 8 and 9 years after their procedures. So, but I've been very pleased. I wouldn't be here talking with all you great people if I wasn't overjoyed with my results so far.
Awesome. What do your patients say to you, Dr. Monajjem, when they come back 6 months out, a year out?
Well, I can tell you that they all fill out a questionnaire when I first see them to evaluate all their symptoms. And when they come back, all of them have put all zeros for their reflux symptoms down the line. And so they're thrilled to be able to circle all of those zeros for the heartburn index and the regurgitation index, and spouses are thrilled that their loved ones aren't getting up and reaching for the nightstand in the middle of the night or getting up and coughing in the middle of the night. So it's pretty gratifying to see how lives have been changed after this procedure.
Awesome. Derek also responded awesome to your answer to his question. So
thank you, Derek.
Can you also just talk a little bit? We've talked about fundoplication. Well, we've talked about medication. We've talked about fundoplication. We've talked about TIF. What are the things that are associated with recovery regarding the TIF procedure and having patients have a successful outcome?
Well, unfortunately, it's not just so simple as you going into surgery and coming out, all completely fixed. There's a little bit of an investment, and that investment is in a pretty significant dietary restrictions over a period of about 4 to 6 weeks. What I usually like to do is if someone comes in that's a candidate for the procedure, I will give them that dietary regimen before we even consider doing the procedure, because everybody loses weight with it. So it's a great preparation for TIF if you know about what the dietary restrictions are, and this is because the procedure itself involves placing fasteners and recreating that valve, and that can cause some swelling and a little bit of discomfort. And we don't want folks to eat a big piece of steak and push it right across that area that's just been operated on. So now there's a graded increase in the level of diet, starting with clear liquids for a few days, full liquids, moving all the way up to regular food. And at the end of that period, usually 4 to 6 weeks, we'll have no restrictions to the diet. With always, there's a little bit of an instruction to just be careful, chew your food really well regardless, and try and avoid eating something that you might think would act as a cork in your new esophageal valve. And then as far as overall recovery, the TIF procedure is usually accompanied by a hiatal hernia repair, which is done laparoscopically. So there are 5 small incisions that usually have very little discomfort associated with them, and maybe there's a little bit of pain. There will be some activity restrictions, but this won't be for much longer than a week or two. And there will always be an instruction to the patient to avoid a sudden straining or forceful contraction of the belly muscles, because this can affect the hiatal hernia repair at any time. No one living on this earth can completely avoid being in a difficult situation that might have to brace themselves pretty heavily. But if you can just be conscious of that, not lose sight of it, that would be very helpful. That will add to the durability of the repair. But as far as strenuous work activity, I'll have patients go back to work without restrictions as soon as they come in and they really feel like they want to go back to work. So, and that's usually within a week and a half to 2 weeks.
Good, thank you. So what are the things that patients say they're able to do or enjoy post-TIF that they weren't able to before?
Oh, well, that's different for everybody, but it really comes down to diet, really, what they can eat, and not everyone has had at some point or another someone tell them that they can't eat something that they really like to eat. This is a situation where if something you can't eat or haven't been able to eat has bothered you so much and we fix it, you can eat it. So that's probably the number one relief is that folks want to get back to their Nashville hot chicken, and they can do that.
Terrific. Very good. Well, Haley, before we wrap up, any other questions that we need to get addressed real quick?
No, I think you did an excellent job of laying out the disease state, the procedure, all the options available to them. I guess I would just ask Dr. Monajjem, because we hear a lot in the field speaking to our family members that know what we do to support this procedure. What would you say to the person who is just nervous about an actual therapeutic procedure, but really is a great candidate through their diagnostic testing or through already having visited their office, their physician? What would you say to them that someone that's just been putting it off for a while?
Well, I think really the most important thing, we don't like to use scare tactics. No one wants to be scared into something. But really the most important thing is the long-term risk of cancer with ongoing reflux. If there's anything that should get you to really consider, even just like we say with folks that don't want to have a colonoscopy because it's a miserable procedure to go through or it's uncomfortable, but the benefits are so far-reaching and profound that it's worth that investment. And that's the essence that I want people to understand about this procedure. Yes, there's some investment in time and effort and maybe some discomfort, but the rewards at the end are you can't compare the two. Far outweigh the negative aspects.
Excellent.
Perfect. Well, I want to thank you so much for joining us this evening. I know the audience got a lot out of the information that you shared, and we're just so appreciative of you spending some time with us. If you are in the Shelbyville area or suffering from symptoms, much like what Dr. Monajjem described earlier, look him up. If you are not in that area and would like to find a TIF trained physician, you can go to our website at girdhelp.com. There is a physician locator tool in the top right corner of the screen. You can enter your zip code and it will provide a listing of physicians in your area. We also have a patient education app that can be utilized for you to navigate your treatment pathway regarding your GERD diagnosis. Provides a lot of useful tools, whether it is tracking your symptoms to help discuss things with your provider, or to record food triggers or other triggers that you might notice, as well as watch videos, read articles on the disease, as well as treatment options that are available. So check it out. It's called GERD Help. You can look for it in your app store and download it. Dr. Monajjem, again, it's been such a pleasure. We really appreciate you joining us this evening, and thank you again. Have a great evening, everyone. We'll see you again for a TIF Talk soon. Bye-bye.
Thank you.
Now that I'm 9+ weeks out from surgery, it's pretty surreal that I keep waiting for heartburn to happen. I keep waiting for the GERD symptoms to come back after I start, implementing foods that I can eat again, and it's not happening. I feel very happy. I feel very grateful. I feel solid in knowing that the TIF procedure worked. I've been running again. I can do push-ups. I can bend over and pick something up without acid coming up into my throat. Yeah, I'm serious. I mean, that's where it had gotten. The dry mouth and the dry throat and dry esophagus, it made it really difficult to speak. And I would get a sore throat a lot from sleep. When I would sleep, the acid would come up into my throat and I would wake up with a sore throat and a hoarse voice. Now I wake up, maybe I think about it because I'm conditioned to think that way, but the cool thing now is that if I do have that thought, which is fluttering away each day, but if I do have that thought, I quickly can scan myself and there's no heartburn, and there's no sore throat, and there's no wheezing, and there's no fear about having a cup of coffee. I just don't wake up feeling defeated and sad and down. I mean, if somebody is having severe GERD symptoms and they've exhausted all their options, even if they haven't exhausted all their options, if they have severe enough symptoms like the symptoms that I had, I would 100% suggest the TIF procedure, because it's been a complete 180 to the way I feel and for the things that I'm able to do now. So if somebody has severe GERD symptoms, chronic acid reflux, I would 100% recommend the TIF procedure.